PARP inhibitors are of great interest in oncology at large. They are currently being investigated and are partially approved, several of them, for ovarian or breast cancer, where PARP inhibitors are particularly active in patients who have BRCA mutations or BRCA-like, as it's called, in breast cancer. So several of these have been shown to be superior to standard therapy, such as chemotherapy, second line or later, and prolonged life, or at least progression-free survival. Now, in lung cancer, we don't as such have mutations in BRCA. There are, however, repair defects in DNA repair pathways. And for some of those, the hypothesis is always that as you create DNA damage and then inhibit repair, and PARP inhibits base excision repair, that you could inflict more damage and be more cytotoxic and lead to a higher response and hopefully even progression-free or survival rates. Now, in non-small cell lung cancer, veliparib is the drug that's been investigated the most. There is a promising phase 2 trial, randomized, of chemotherapy plus minus veliparib that has just been published by Suresh Ramalingam in Clinical Cancer Research, and it does show a difference, particularly in smokers, where arguably there's already more DNA damage, and then as patients are treated with chemotherapy, the PARP inhibitor is added, they might be even more susceptible to that added damage. Now, there's been a follow-up trial that's been completed, that's been announced in the press as negative, so that there is likely a disappointment just ahead when we see the actual data. But I think we need to see the actual data and have some impression as to, is there a trend, is it progression-free, is it overall survival, are there any subgroups, are there molecular analyses that allow us to be a bit more specific. So that's where we are in stage 4 non-small cell lung cancer. There are also trials ongoing that add veliparib to chemo and radiotherapy, and particularly with carboplatin and Taxol and radiation. 2 phase 1 studies, one done by the SWOG and one done currently by the Alliance, that show that veliparib can be added in the SWOG trial up to 120 milligrams daily BID, and in the CLGB trial or Alliance trial, we're currently testing a dose of 240 BID, so a somewhat higher dose. Now, that may then go further into investigation. In fact, SWOG has opened currently a randomized phase 2 trial for veliparib plus chemoradiation plus minus veliparib.